Hi, this is Brian Kim. I'm going to share with you case number 29 in the Best Way to Do Cataract Surgery series. This is a small lens with a medium-sized pupil, but I'm going to show you how using mechanical fracturing, double chop, cross chop, using the chopper to pull the lens pieces out of the bag makes this such an easy type of case. You don't have to worry about the lens cheese wiring or falling apart when you're doing the disassembly of the lens. So here I'm going to make my paracentesis incisions. I'm using a cotton tip to turn the eye, which will allow me to flatten the eye to get a flat approach with my paracentesis blade. By making it flat to the iris, I can get a nice self-sealing corneal incision. I'm injecting some intracameral lidocaine and epinephrine to see if I can dilate the pupil a little bit. Not much of a response with that, but then I'm using the viscoelastic to inflate the anterior chamber, which I get good viscodilation. I'm going to do my triplanar corneal incision. I make a vertical groove, go into the groove, tunnel through the cornea, and then enter, and this is a triplanar corneal incision. I do my puncture-style capsulorhexis, puncturing and then pulling downward, getting a nice little C-shaped flap, going around circumferentially, using my corneal mark to help me center and size my rhexis. I'm trying to grab intermittently, again, following the contour of the marks, going around periodically, grasping and regrasping, and then finishing the rhexis. And then I burp the viscoelastic out of the eye. This is my Capsulorhexis hydrodissection technique. Place the cannula out to the contralateral equator, underneath the anterior Capsulorhexis edge into the Capsulorhexis, point the tip down, and you get a nice fluid wave, decompressed on the left side. And then I'm going to spin the lens on the right side, turning the cannula tip downward. You can see I'm getting a nice rotation of the lens. Begin the cataract surgery. I'm going to lift the incision with irrigation off and then enter with the phaco tip. This minimizes Descemet's trauma. And then I'm going in with the chopper. I'm going to remove the surface epinuclear material, which will allow me to create an epinuclear ridge so that I can place the chopper out to the equator, placing it out underneath the ridge, turning the chopper into the Capsulorhexis, placing the phaco tip vertically, and then crushing the lens with the chopper and the phaco tip. This is a double chop. I'm placing the chopper out to the contralateral equator, pulling the chopper centrally toward the phaco tip, dividing the right heminucleus, and this is the cross chop maneuver. I place the chopper out to the equator again, pulling it centrally to the phaco tip, crushing and dividing that first quadrant, and then it's beginning to be emulsified using high vacuum. And with high vacuum, the second quadrant tumbles into the phaco tip, and so I'm using high vacuum and then using the chopper to crush it into smaller pieces and emulsify it. And then I'm going to rotate the lens in front of me. This is a second heminucleus. Place the chopper out to the equator, placing the phaco tip deep in the bag, crushing the second heminucleus. Grasping the third quadrant with the high vacuum and then crushing the lens between the chopper and the phaco tip. And you can see that the lens is coming out quite nicely. This is the fourth quadrant. I'm going underneath the epinuclear ridge and then crushing the lens between the chopper and the phaco tip, and then using high vacuum and then crushing the lens with the chopper. All the endonucleus has been removed, and now I'm going to remove the epinucleus. I'm using the chopper to protect the posterior capsule as I remove the epinuclear shell. I take the chopper out, and then we use a BSS cannula to keep the eye inflated, take the phaco tip out, and then replace it with the eye in a handpiece. And start subincisionally removing the cortical material. I always start subincisionally because this is, in theory, the hardest part to get out, and I like to have a fairly robust cushion of cortical material as I go after the subincisional cortical material. But as you can see here, the epinucleus is quite loose, and that's from a very good hydrodissection. And now I'm going to begin to polish around the lens, first underneath the anterior Capsulorhexis edge. When I don't have good visualization of the anterior Capsulorhexis edge due to the smallish pupil, I like to go to the polish mode fairly early because I don't want to accidentally pull on the zonules as I do the cortical cleanup and removing the lens epithelial cells. I'm using the cannula to pulse the subincisional Capsulorhexis. You can see there's some cortical material being liberated. and then I come out and inject some cohesive viscoelastic into the bag and pulling out the INA handpiece. I begin to sweep on the left side of the anterior capsulorhexis edge. Because of the visualization is limited, I'm going to do just a very limited polishing of the anterior capsule. And then this is the single piece acrylic intraocular lens. I'm going to inject it into the capsular bag with the leading haptic into the bag, the trailing haptic out of the bag. I'm going to place my INA handpiece, making sure both haptics are free of the optic. Once I'm sure the haptics are free, I'm going to rotate the optic 90 degrees clockwise, and I'm tilting it, so I'm making sure that both haptics are definitely in the bag by tilting it and pushing it into the capsular fornix. I'm removing the viscoelastic from underneath the lens and in the bag, and then I'm removing the viscoelastic in the anterior chamber. Once the viscoelastic is all removed, I'm going to push BSS, come out with the INA handpiece, and then hydrate my incisions. So again, this is a soft lens, medium-sized pupil. You can see that the pupil size does not interfere with my ability to do the surgery because all of the movements are within the capsular bag. I'm using the chopper and the phaco tip to crush the lens pieces using mechanical fracturing forces, crushing the lens pieces into smaller pieces, also mobilizing the lens pieces. Instead of trying to grab the lens with the high vacuum or ultrasonic energy, I'm using the chopper to prolapse the lens pieces out of the bag, which means I can pull the lens pieces out of the bag regardless of the location or position. This is a very versatile way to do cataract surgery, especially for these soft lenses and smaller size pupils. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.